which the delegates will be presenting on various topics. The structure of this section will be as follows. Each delegate will be given 6 minutes to speak on their topic, and at the 5-minute mark, there will be a buzzer noise to let the delegate know that there is 1 minute left. The buzzer will sound like this. One moment, I think the sound is loading. Okay, I think we can move on, but at the 5-minute mark, there will be a noise to alert you that there's 1 minute left. And so we request the delegates to stop sharing their screen after their presentation is complete, so then we're able to introduce the next speaker who will then be able to share their presentation.
Starting off will be Dr. Kiran Kumar Makineni, who is a consultant vascular surgeon. He served as an assistant in surgery and has presented many scientific papers across India. He will be presenting on the prevalence and preventative measures of venous thromboembolism among COVID-19 survivors. Please start sharing your screen.
We welcome Dr. Kiran Makineni. Can you please go ahead?
You can hear what I'm saying?
Yes,
Hello?
please. Yeah, please go ahead.
Are you getting the audio?
Yes.
Yeah, okay. Deep vein thrombosis is one of the most common preventable cause of death in US or in India. Today we are going to talk about prevalence and the preventive measures for thromboembolism among COVID patients. We all know that COVID has taken us by storm. There are numerous reports of patients with COVID infection presenting with deep vein thrombosis or arterial complications. In our routine practice as vascular surgeon in India, we are seeing increased number of patients presenting with acute MI, stroke, or lower limb or upper limb acute ischemic symptoms. We also see that numerous patients are presenting with severe deep vein thrombosis, not mild or moderate symptoms. Most of these patients come with severe pain in the lower limbs. You are also seeing upper limb DVT, which is less common before. Some of these patients are diagnosed case of COVID-19 who have taken treatment but were not on thromboprophylaxis. Some of these patients have presented with thrombosis. It can be arterial or it can be venous. The rate of pulmonary thromboembolism detected in the intensive care units is about 20%. In non-COVID cases, it is less than 2%. The overall prevalence of DVT was around 14% in among ICU or non-ICU patients who are admitted. But patients who are not admitted in ICU or with mild to moderate disease, it was found to be around 8%. There is a problem with exact prevalence or incidence of deep vein thrombosis or thromboembolism because of the fact that most of the data is still coming in, even in US, UK, or in Europe. In India, still a lot of studies have to come in. Very few centers are actively participating in collecting data and studying. At the moment, very little is known on the exact prevalence in hospitalized patients or symptomatic patients. This is due to the fact that there is difficulty in performing routine ultrasound or CT pulmonary angiogram in most of these cases. There are few studies which have been published in Europe or China. The approximate incidence is something between 25 to 27%. But patients in intensive care units who are symptomatic or patients on ventilators, it increases to almost 50%. That is 1 in 2 patients has thromboembolism. Basically, COVID-19 itself is a classical example of Virchow's triad because you see all the three factors in this. Coming to preventive measures, routine post-discharge VT prophylaxis is not recommended as of now. VT prophylaxis for certain high-risk post-discharge patients or non-hospitalized patients with COVID-19 should be considered after proper evaluation. This includes clinical examination and following one of the scoring systems depending on the hospital or institute you are working in. All the patients who are discharged after treatment for COVID as ICU or non-ICU settings or patients in home quarantine should be assessed for risk of thrombosis, because in India we are seeing that majority of these patients are diabetics, hypertensives or old people. It is important to sensitize the patients as well as ER staff as to the danger signs of arterial and venous thrombosis, both at the time of discharge or at the time of OP-based treatment or counseling of this patient. It is also important for us to inform all patients who are on home quarantine, because in India, at the present given time, due to lack of sufficient hospital beds, majority of the patients who are with moderate symptoms or are asymptomatic are in home quarantine. At the time of discharge, all patients, regardless of risk factors, should be assessed, because some patients will have continued need for oxygen support at home. There can be coexisting diseases or morbidity. Prolonged immobility during quarantine may be there. We have to assess D-dimer, CRP, ferritin, and lactate dehydrated in patients who are symptomatic. Elevated inflammatory markers indicate the need for continued prophylaxis even at home. Early mobilization of patients at home is important because most of the patients are isolated in a single room, and patients with small houses, they may be in a very small room. Some of them may need oxygen, so they may be attached to the bed. Adequate hydration is very important, because I have seen few cases where the patient has fever or is symptomatic, he takes very little amount of water. This dehydration itself precipitates deep vein thrombosis. Most of the patients who are discharged who are symptomatic, chest physiotherapy and breathing exercises are very important. You should also monitor these patients for secondary infections, because we are keeping most of these patients on steroids. They are susceptible and they are immunocompromised. This is important slide because in our routine practice, I've seen so many patients coming to the outpatient department with gangrene of the lower limbs or upper limbs, or severe deep vein thrombosis with swollen limb. So it is important because some of these patients have gone to primary health centers where the nursing staff have not identified that the patient may have acute thrombosis in the arterial or venous system, because they are not sensitized according to that. So in case of venous thromboembolism, you should always look for swelling of a leg or arm, severe pain, sudden onset of pain, redness or warmness of the limb. In case of pulmonary embolism, look for chest pain, cough, increased heart rate, dyspnea, and sudden onset of hypotension. You should also look for symptoms and signs of stroke or transient ischemic attack, sudden onset of chest pain, angina, sudden onset abdominal pain, which shows that mesenteric vessels are thrombosed. Look for signs of peripheral arterial disease, like I told, discoloration of the legs, discoloration of the toes or fingers, sudden onset severe pain, numbness or weakness of a single limb. You can also see that I have seen a few cases where patients on regular hemodialysis have presented with sudden occlusion of their permicals or hemodialysis catheters or AV fistulas. On evaluation, we found that these patients are asymptomatic COVID-19 cases. Patients with what is the required treatment for these patients? Patients who need thromboprophylaxis if they have mild to moderate risk of VTE. Enoxaparin or low molecular weight heparin sub 40 milligrams subcutaneously will be sufficient. Fondaparinux 2.5 mg subcutaneously also can be given. Patients with renal impairment, we can use unfractionated heparin. NOACs or DOACs can be used if there is no contraindication. It is easy to use, and I think patients will be more ready to use oral medication than using injectables. Sorry, I missed this slide. Patients with diagnosed deep vein thrombosis or patients with suspected deep vein thrombosis or increased levels of D-dimer need full dose anticoagulation in the form of 1 milligram per kg body weight of low molecular weight heparin like enoxaparin or full dose oral anticoagulants. Thank you.
It is an excellent talk, Dr. Kiran.
Okay. Yeah.
So, Dr. Nandakishore garu, can you please take over?
Thank you, Dr. Kiran Makineni garu. It is always a learning from you, sir. Dr. Kiran Makineni garu is the first vascular surgeon, first batch from Nizam's Institute of Medical Sciences. And he is the only vascular surgeon fighting to save people around nearly 150 miles square area. And he is saving millions of lives over there. And is a very big force in educating people and raising awareness among his fellow colleagues. Thank you, sir. Thanks for your time and a fantastic lecture.
Thank you. That was very nice.